Good afternoon to everyone. It is, as I said, my absolute pleasure to welcome all of you to today's session, which is a guidelines training on the use of oral pre-exposure prophylaxis and non-occupational post-exposure prophylaxis in Caribbean countries. Today's session is hosted by the Pan-Caribbean Partnership Against HIV/AIDS, PANCAP, with the technical support from the Pan American Health Organization, PAHO. My name is Dr. Keisha Chin, the National STI Program Coordinator at the National AIDS Program Secretariat, Ministry of Health, Guyana, and I'm also your chairperson for today's virtual gathering. I would now like to welcome Dr. Shanti Singh Anthony, the Knowledge Management Coordinator at PANCAP, for her to give her opening remarks and to guide us through the background and objectives for today's activity. Dr. Singh, over to you.
Thank you very much, Dr. Chen. I want to say welcome on behalf of Dr. Wendy Emmanuel Sontelk, who is the PANCAP director. Unfortunately, she cannot be with us this afternoon, but she extends her warmest welcome to everybody here this afternoon and for tomorrow afternoon's session as well. By way of background, what we wanted to share, and a lot of this you already know, PrEP is a proven prevention tool. It works. And so while this has been proven scientifically, and you will hear some of the evidence today in one of the earlier presentations, our uptake in the Caribbean has not been as we would want it to be. It's not as high as we would like it to be. But nonetheless, going back a little bit, the region has been making progress in terms of prevention. And therefore, with this proven prevention tool, which is PrEP, we believe that if we're to scale this up and have more people who are at risk for HIV on PrEP, then we can continue to make even bigger strides in terms of prevention of HIV in the region, and thereby taking us to some of those global targets and milestones that we have to achieve by 2030. And so this training really, in some ways, is coming on the heels of a learning journey that PANCAP organized in April of this year, where a group of Caribbean persons were able to participate with the Public Health Institute of Amsterdam and be able to see some of their programs, some of their initiatives, some of their strategies that they have used to really reduce HIV infections in their programs. And so again, at that learning journey, PrEP came up as a tool that we really need to be able to scale up in the Caribbean region. Parallel to that, at PANCAP, we have been receiving requests from countries to conduct this training. We've done this training before for some countries, and we've done this training. Every time we've done it in collaboration with the Pan American Health Organization. And again, this one is being done in collaboration with the Pan American Health Organization. And so this training was done, for example, with the Belize program. It was done for the OECS countries. It was done with Guyana. And so this one now we're bringing on board representatives or participation from all of the Caribbean countries. And so very diverse group of practitioners that we have with us this afternoon and for tomorrow. And so with that as a background, we felt that it was important for us to really be able to spend some time with you for these 2 afternoons to provide the knowledge that you need to have so that you can scale up, onboard, and scale up your PrEP programs. And so the general objective really is to provide our healthcare workers, our healthcare providers, information and knowledge on the use of PrEP, and we've included post-exposure prophylaxis as well, non-occupational post-exposure prophylaxis as well, within the context of SRH, sexual and reproductive health, with the overall aim of supporting the effective scale-up of your services across Caribbean countries. And so based on the specific objectives, which really are to share updated national and WHO guidelines on PrEP and PEP, to be able to address some of the social determinants of health, looking particularly at things like stigma and discrimination as key factors that influence people's uptake and access to services. You will hear the very first presentation will be talking about what are some of the barriers and the challenges we've encountered across the region at the country level and across the region and in implementing PrEP, and what are some of the opportunities for us to really be able to scale up PrEP across our countries. And so based on those specific objectives, you will hear presentations that will touch on each one of those. And then finally, we will share with you some of the tools or the recommended tools recommended by WHO that we have also adapted to the Caribbean region, and we're recommending for countries to use in their programs so that you can effectively monitor and evaluate your PrEP programs. And so again, this is a training in collaboration with the Pan American Health Organization with technical support from the Pan American Health Organization. And so on behalf of Dr. Wendy Emmanuel Santelk, the director of PANCAP, I want to say big thanks to PAHO, to Dr. Hortensia Peralta, who you'll hear from, and Ms. Sandra Jones from the sub-regional office. I also want to say thanks to Dr. Keisha Chin and Dr. Divya Shivdas for, at very short notice, agreeing to lead two of the technical presentations. And I say this because I would like to apologize to everyone at this point in time because I will have to step out in another hour or so, and I will not be present tomorrow, but you're in good hands. Dr. Hortensia is here, Ms. Sandra Jones, Dr. Divya Shivdas, Dr. Keisha Chin, and we have supporting the team our communication specialist, Mr. Richard Francois. So with that, again, welcome. I trust that all of the knowledge that will be transferred to you today and tomorrow, that you will be able to apply them, whether it's in your broader program, whether it's to advocate for policies, but that you'll be able to apply them when you see your patients and you manage your patients, or when you recruit people into PrEP programs. And so with that, thank you, and over again to you, Dr. Chin.
Thank you very much, Dr. Singh, for your remarks. And again, I would just want to echo the sentiments that for today's capacity building session, we're certainly honored to have with us a very dynamic lineup of speakers having with us present, Dr. Peralta, Dr. Shivdas, and of course, Ms. Sandra Jones. So before we move on to the sessions that we have tabled for today, I just want to say to you, the participants, sharing a bit of knowledge with you. You'll be pleased to know that today's session, you will be provided with a certificate of participation. If you participate in only today's session, your certificate will reflect the same. But however, we do have another session tomorrow that's continuing and it's building on information and knowledge that you would obtain for today. So we actually encourage you to try your best to be present and to participate in both sessions, and your certificate will reflect once you participate or you're present for both days. At the end of the session as well, we will be providing a sort of link for you to an evaluation link for you to be able to complete that as part of the program that we have slated for you today and tomorrow. So without further ado, I would like to now welcome Dr. Peralta, Advisor for HIV Prevention at PAHO. Dr. Peralta, over to you.
Thank you, Dr. Divya. I just want to say thank you to you, to PANCAP, and also welcome to Sandra. Sandra is our regional advisor for the Caribbean. All you know, Sandra. And we will start this training with the Mentimeter. This is my first assignment. In the chat, I put for you the code is 7289160. Please go to the web and put www.menti.com. I will share my screen. Okay. Please, I would try to enter in my mm, please, okay. Please, give like okay. Just for now, if you can enter to the Mentimeter. First of all, that I want to say welcome to the workshop. We want to ask some, I say fun. I don't know if it's really fun, but we try to make dynamic. The idea of the Mentimeter is allow you to interact with everyone in this workshop. I know the virtual training is challenge, especially because we have another activities competing for our time. Please give us this 2 hour and a half, 3 hours of your time for talk about prophylaxis pre-exposure. That is a very important subject, very important issue that that Shanti mentioned before. Okay, I don't know how many people are in there, but I will start, okay? The first question is what is in one word? Okay, we need to try to do this in one word. That describe how you feel right now. Please are 34 person in the Mentimeter. Please enter, use your code, and try to write in one word how you feel right now.
Apple. I do.
Okay. I hope that the person is feeling hot is because of the weather, but if not, well, I don't know how is the weather there, but I can see the majority feel happy. Someone is hungry. Yeah, it's true. This is a very difficult time. Please, if you feel sleepy, try to maybe put on your feet and try to make some legs movement. Some people feel blessed, curious, powerful, interests, anxious. No, you don't need to feel anxious because this will be a smooth and relaxed training. We're trying to meet the expectation from everyone. Okay, so many people feel tired. Maybe we need, in one moment, we need to put on our feet, try to make some arm moves or try to move in the during the training. I will move to another. I think that some people feel optimistic, powerful, um, relaxed. Some people feel gay. There's okay,
Fancy.
very good. Okay, the next question
Of
is
course. Don't corrupt too.
sorry.
No, because idea gonna have the real bomb should be. I don't know.
I think someone's mic
Me?
is
What?
open.
Okay.
I'll try to see if I can do that
Please,
first.
to the co-host, help me to mute the phones, the microphones. The next question is, what is the best word for describe your work duty? In this case, we're trying to know if you are physician, if you are nurse, if you are community health worker, uh, if you make prevention, testing, HIV care, okay. If you are clinician, if you see people on service, what do you think is the best word for describe your work duties? Okay, we can see that we have a very diverse audience. We have policy making, supervision, surveillance, director, multitasking, pharmacists, HIV prevention and care, healthcare provider. It's good that someone described your work duty that challenging because we need some challenge in our daily work. Maybe not so much, but every time I think this is good. The in the moment that we are in the workshop that is happen virtual, that is challenging. My first motivation is trying to share our experience with you, and probably at the end of the day one and the day two, have a good discussion with all of you. This is an open question also. What do you think is the best intervention for reducing new HIV infection? In a few words, please don't write a lot because this is a Mentimeter, but this is something that we can help us to redirect the training uh, related with your knowledge. Okay, what do you think is the best intervention for reducing new HIV infections? Okay, ongoing education, prevention, education, viral suppression, support, PrEP, availability of service, bring awareness, proper education to, I think, is patients, combination prevention strategies, treatment and prevention, prevention education, continued education, public education, social media display, treatment and prevention, information, safe sex, health education, more education, ongoing education. That is good. Education is the best tool to change the world. This is not my word, but it is a true word. We need to enhance education to all at once, not just for the person, not just for the user, the client, but also for us like a health workers, okay? Awareness, prevention, screening. Okay, all these combinations are true. One of important here is not judgmental care, not only care, I said not judgmental approaches. I'm not sure if the abstinence is part of the HIV combination prevention, but we can receive all the ideas that you give us. Okay. But the main word is education, prevention. Okay. Please, this question is just for trying to know our audience. Please tell us what is your gender. It's a lot of options: male, female, transgender man, transgender woman, non-binary, genderqueer. If you prefer not to say, or if you have another, please tell us. Okay. The majority of the audience is female. Okay. Good. We have 43 answers, and we can continue. This is good. In our workshop agenda today, in the first PowerPoint presentation, Sandra is going to talk about the PrEP in the Caribbean. And then our our chair will talk about overview in oral PrEP, especially in the efficacy and the evidence to support oral PrEP. And then I will talk about the PrEP prescribing, different modalities, indication, adverse effects, and other issues. At the end of this today, we will know what is PrEP, what PrEP does and what doesn't, what type of prophylaxis pre-exposure exists, what modalities, what are the indications, what is HIV substantial risk, what is the situation in the Caribbean, the lesson learned and the challenge. And we will have a discussion, clinical discussion for 2 cases, just in order to support our knowledge achieved today. Please tell us how many times have you received training on PrEP, on PEP? Okay. We have a lot of people that not receive none training of in PEP or PrEP. I can see at least 14 receive 1, and we have 9 persons that receive 3 or more. That is good because this can help us in the discussion. For the people that at this time doesn't receive any training, okay? That is good. And please tell us, what are your expectations for this workshop? Please be brief, not write so much, because we're trying to give opportunity to everyone. But it's important for us to know what are your expectations for this workshop, because if in the day 1 we can achieve your expectation, probably we're trying to write direct in the second day. Okay, to refresh my memory on PrEP, to increase knowledge of PrEP and PEP, to gain more knowledge, learn about PrEP and PEP, learn about PrEP and PEP, learn about the choices for PrEP, input on how to increase uptake in our population. This is very important. Learn new data, enhance capacity to learn and build on my skills. Learn about PrEP guidelines, to learn, increase awareness, anything new related to PrEP and how to relate to individual responsibility, to increase knowledge, update knowledge and current recommendation. That is for tomorrow. Tomorrow we will see the new WHO recommendations. Please stay tuned and come tomorrow. We will talk some today, but in more deeper way tomorrow. Gain knowledge. Okay, that's good, because I feel that everyone that is here is committed to the action, to the workshop, to gain knowledge, to know more about PrEP and also post-exposure prophylaxis. And this is good, because I think we are here voluntarily, and because we want to learn, and we want to have new information, and we want to collaborate with our countries to support the PrEP implementation. In this order of ideas, please tell us, what do you think? What are the challenges that do you face in your country for PrEP implementations? Okay, patient refuse meds. Not sure. That's fine. That is possible also. Compliance. Lack public awareness, poverty and some don't access healthcare easily, administrative and different opinions, especially from religious leaders. Patients have outdated opinions on HIV and prevention. Well, not only patients, sometimes healthcare workers, community leaders have outdated opinion on HIV and prevention. And for that reason, we need to make training, workshop of social media, no active program. That is something that we need to address because the majority of the country have an active program for PrEP. A stigma, there's a lack of information of the benefit of PrEP. Patients need to be educated, lack of awareness. Patients are in denial, refuse treatment, logistical difficulties for person to receive PrEP, limiting laws. Okay, maybe in the discussion we can talk about what type of laws are limiting PrEP implementation. Human resources, medication shortage. We need to maybe in the discussion address also this issue because PrEP is oral PrEP is a very affordable intervention. Campaigning more effectively PrEP and PrEP stigma. Okay, I think it's the last one. Okay. Which topics are you most interested in discussing today? PrEP and PEP, new WHO recommendation, or the discussion? This is in order to try to organize the time for, okay. Like I said before, new WHO recommendation in deep way we will talk tomorrow, but we start today. PrEP and PEP, that's good. Maybe we need to talk a lot for ANPEP because maybe we need to know why the people is not so interested in discuss ANPEP, okay? And in a short sentence, please let us know what do you think about PrEP. Is useful? It's not useful? It's good? It's bad? I don't know. You have better words than me, that for sure. It's necessary? It's not necessary? Okay, it is beneficial. It can reduce transmission. It's needed. It's useful. It is hard to get people interested in the service. Very innovative. Game changer. Definitely necessary. Useful, helpful. Important factor to reduce HIV prevention. Can be useful. It is necessary. I believe it's necessary. From the little I have read, it's useful to prevent transmission. Okay.
Can I just ask that everyone respond using the Mentimeter? Because I think people are still putting their responses in the group chat rather than using the Mentimeter or logging in so that the responses could actually be visible on the screen.
Okay. Don't worry. I will review the chat. Maybe someone can be able to open the Mentimeter, but we have a very good number of answer in the Mentimeter for our discussion to give us any ideas about the audience. That is the most important thing of this Mentimeter. Okay, thank you. Okay. I will summarize this Mentimeter for tomorrow, Sandra. And thank you for all you to answer the Mentimeter. I will also review the chat. If I found an answer in the chat, I will trying to put in the Mentimeter because we can use the Mentimeter for 2 days with the same code, okay? If you want to answer and complete the answer, you can use the code and continue answering in this Mentimeter. To continue to our schedule, at this moment, Miss Sandra Jones, HIV, STI, and tuberculosis and viral hepatitis, and EMTCT advisor, and the Caribbean Subregional Office is continuing with the training. Thank you, Sandra.
Thank you very much. And Hortense, I would ask you to please go
Yeah.
ahead and share the slide for me. But I want to say how excited I am. So hello, good afternoon, buenos dias, bon tarde. Good afternoon to each and everyone across the Caribbean who joined this training. I realize that we have like 142 persons connected, and this is exciting. It is wonderful because it shows that people are interested as clinicians, as healthcare workers. You're very much interested in learning more about PrEP to increase the intervention to reduce HIV prevention at the country level and by extension across the region, and for you to take 3 hours out of your busy schedule to join the training, it's very impressive, and I say thank you very much on behalf of PAHO and PANCAP, and also to say thank you for embarking on the implementation of PrEP in your country. PrEP is not new, as you would know. It has been around since about 2015. It took us some time in the Caribbean to start to implement this high impact intervention for HIV prevention. But we're seeing where it may be small, but the momentum, it's actually growing, and we have more and more persons that are implementing. And I noted that in this training, there are some people who are on for the first time. And this is also showing that we have a wider that the cadre of persons in the Caribbean to implement the PrEP is growing. So thank you very much. Very quickly, because I know we have time. Time is not on our side. Very quickly, I would just like to review what are some of the lessons that we have learned from the implementation of PrEP. Since I would say I would go back to 2021, 2022, when these were some of, I would say, most of the countries started to implement PrEP on a larger scale. Some may have been smaller here and there within the private sector. And of course, with the exception of Bahamas, which I think started in 2016, and Barbados about 2018, more or less, right? At PAHO, we continue to support the regional training in collaboration with PANCAP, and also at the national level if country requested through the country offices. And over the years, with the support of PANCAB, with various workshops, meetings, and seminars, the issue as it relates to the implementation of PrEP came up. We have addressed it, looking at what are some of the challenges. And so I just want to take some time at this moment to just highlight what have been some of the lessons learned that have come out of some of the discussions that we have had, informal or formal discussions. We all know that PrEP is an integral part of and is part of a wider combination HIV prevention program. But we also, for those who are implementing, to also realized that there are some issues with the implementation. The manner in which the PrEP is established and implemented will determine the outcome. And so, what do I mean by this? We have heard through numerous occasions that the implementation of PrEP, when it is rolled out, focusing on key population, those that are at high risk for acquiring HIV, which for most people this means key population MSM sex workers, can often be a major barrier for the service, sometimes even for the approval of the service, and it, of course, brings about discrimination. And so, therefore, presenting PrEP as a key prevention strategy to reduce new infections, regardless of who the individual may be, and providing PrEP to discordant couples, to everyone, may reduce negative consequence of the service. So that is one of the major things that we have heard, and we have heard this mentioned across the board by different countries. Also, within this framework, the country context and the environment must be realized and understood. For instance, in establishing the service, it is important to define the model that is best suitable for the country. Will it include a combination of public-private facilities, civil society organizations such as those that are involved in sexual and reproductive health, so that it could give options as to where people will feel more comfortable accessing services? We know that this is an intervention that will help to reduce infections among key population. So another thing, when this is being, as you're thinking about expanding based on the lesson learned, what will the role of CSO organization be? And in this case, I'm not saying only the CSOs that are involved with working with the key population, but other organizations as well. In addition, for some countries, it was important for some countries because of all the stigma that is associated with PrEP. And I saw that came up several times in the Mentimeter. For some countries, it was important to roll out the service without any major promotion to avoid negative consequences. So the promotion would have been just within the target population, MSM, transgender, just the key population. While for others, the rollout and the implementation was completed with the involvement of key population. There were flyers, there were billboards, and there were pamphlets that were utilized. So we have learned that country context really helps a lot, the entire environment. As I said earlier, there is no doubt, well, we're very happy as to the number of countries that are implementing PrEP. We went from 2 countries in 2016, and I think now we have, I cannot think about any of the countries in one level of or the other that is not implementing PrEP. So we know that as a region, we have made considerable stride despite some of the challenges with the implementation of PrEP. Some from having the interventions implemented to ensure that they reach the entire population. But what we have seen with the implementation of PrEP, for most part, it is basically, if I would want to say, standalone. It is implemented in care and treatment programs or in particular care and treatment programs, but the integration of the PrEP services into existing services such as sexual and reproductive health, STI services, among others. These are some of the things that, from lessons learned, can be considered and perhaps be helpful to address some of the issues that we have seen, some of the biases and the stigma that is attached to the use of PrEP and accessing PrEP services. We have seen where that over the years, the uptake, even for the countries that have started much earlier, the uptake is not as would have expected. And so countries have looked at different innovations, and it's very good. Innovations, very good. And it's critical to be very good to be innovative. But when we're looking at innovation and scaling up the services and reaching more people, we must plan it very thoroughly. We have seen where some countries have identified and implemented innovations to promote the service differently. For example, outreach programs, and we commend this, but this is not done in a structured manner to ensure that these desired outcomes are realized. The need for critical analysis of the structure and what is available and how the follow-up services will be implemented and will continue. These continue to be some of those challenges where countries have developed innovative approach to reach out to individuals. We have seen where the limited knowledge and the awareness of PrEP may also affect the uptake. And I notice in the Mentimeter, people talk about limited knowledge and the understanding of PrEP. I recall I think it was 3 years ago, there was a study that was done in a particular country, and the study revealed that there were persons who were not knowledgeable of PrEP, how it works, where to go get it if they want to. They had so many questions about PrEP. And of course, when this study was done, it was done within the key populations. But then this also may reflect the reality of the general population. And so this brings to the point where we have seen that for most individuals accessing PrEP, they had to request PrEP. So the question is it offered based on the service that the individual is accessed? Is this something that is offered, or persons have to go and seek out the PrEP? So these are some of the things that we're seeing, and just putting this out there for consideration as a region, as country, we are thinking about the expansion and the strengthening of the PrEP services. The rollout of PrEP, we have also seen, and from discussion with countries, is focused mainly on the daily oral PrEP, with not much emphasis on event-driven PrEP or on-demand PrEP. As expansion is made to the service consideration, it will be good for greater emphasis to be placed on the rollout of demand PrEP, and to ensure that approaches adapted, that there are approaches that are adapted to actually facilitate this. Because as I go back to what I saw in the Menti, some people were saying that people don't want to take the pills, and it is true. So there may not be a need for somebody to take a pill every day, but maybe we would need to actually look at the promotion of the on-demand PrEP. We have also seen, and this was something that was very striking in I think it was Dr. Singh spoke about earlier about the a PrEP mission to Amsterdam, and we recall as countries were actually discussing the PrEP services and what they're implementing and some of their challenges. We realized that some countries may change the algorithm and the rapid diagnostic, adding a layer of intervention, which may delay a person accessing the real PrEP. And so this may also limit persons accessing PrEP, the when and in a timely manner. And it may not even, they may not even return after their first encounter with the health system. The sensitization training is very critical. It's not only should be the persons who are and this is to address the lack of the information. Not only do we want persons who are giving and dispensing and talking to healthcare providers, to persons about PrEP, but the training of all healthcare workers, all those who are involved in knowing what is PrEP, the value of taking PrEP, so that people can share this information. We have a snowball effect of the PrEP information and awareness, because it's not only to share with the clients, but also to actually share within our own network of families and friends. Can we go to the next slide, please? And I'm about to wrap up here. Very quickly, just before I end, I just want to focus on two major gaps and challenges that as I have already addressed some of those as we were looking at lessons learned. As I mentioned earlier, PrEP is part of an HIV combination approach, offering comprehensive interventions to ensure the reduction of new infections. But what we have seen in our discussion with countries, it appears that the PrEP is the only thing that is given, but the intervention, the testing, and well, the screening for syphilis and hepatitis B as part of the PrEP services, that part is always eliminated. And it's only about giving the PrEP. And we at PAHO, we are trying to encourage a holistic HIV prevention services, because we do know that syphilis and hepatitis, viral hepatitis, these are ongoing challenges. And I'm not only referring to hepatitis B, but also hepatitis C as part of the interventions for inclusion in the PrEP. And my last point I want to actually focus on here is that in the Caribbean, there was a standardized tool, well, a generic guideline for the PrEP service developed, and it also includes standardized tools and register for PrEP. It appears not to be using as much, and so it is very difficult that the limited data that we get from country to analyze the data to actually determine what is happening in the region and the overall impact. Many times countries would ask us, and PANCAP also, they would get the question, what is the PrEP experience in the Caribbean? What is happening? What is the data showing? But because the data is not collected in a standardized manner, it is very difficult for us to answer those questions and to provide you with the information. I know tomorrow there's a session where we'll be looking at indicators, and I think we will take some time to very quickly look at some of what are those standardized tools and the register to actually support the effective availability of reliable data to profile what is happening in the Caribbean. So this is no doubt extensive. This is just some of the areas that we have identified, that I've shared. I thank you very much for your participation once again and for your attention. And I turn back over now to Hortensia. Hortensia, back to you. Thank you very much.
Thank you, Sandra. I think Dr. Kiesha.
Yes, I'll go ahead. Thank you very much.
Thank you.
Yes, so thank you very much to Ms. Sandra Jones for your very insightful presentation. You definitely touched on the facilitators and various challenges for PrEP implementation and service expansion. Looking at just a minute. Participants, please ensure that your mics are muted. Just a minute, let me find that person.
I will.
Yes. So I was saying that, Ms. Jones, you touched on very importantly on the facilitators and challenges at the various levels, whether it's at the level of the client, the provider, or challenges and facilitators at the structural level. Definitely also looking at how best as it relates to the implementation of PrEP and then its subsequent expansion. We want it to be evidence-based, utilizing best practices from countries that are currently offering PrEP services. Definitely touched on its importance for integration into primary health services, whether it's at your community health centers or even within your family's family planning services as well. So I think I've said a lot. I am going to run the chat to see if there are any questions. I don't notice any questions in the chat. So I'm going to open the floor for if any of the participants would like to make any comments or ask any questions. I see someone. Okay, you can go ahead. Nancy Bando, I hope I pronounced that correctly. You can go ahead.
Thank you very much. I have a question. I understand that PAHO is, in fact, supporting the fact that we should also be doing other tests like syphilis and hepatitis. But I'm just wondering how much communication there is between PAHO and, for instance, Global Fund as one of the funders of the PrEP programs in different countries. As we understood in our last year meeting in Geneva from Global Fund, that we should only be doing the HIV testing and not other tests. So they were not willing to pay for the other tests. So how is the communication if PAHO on one side has a certain perception? Is that shared with the other donors? And how is the communication on one side and how is the collaboration to see how those policies of the different donors could be brought together in the context of the country?
Hortensia, do you want me to get that or you want to go ahead?
Sandra, I think the question is more programmatic or political in the context that technical. If you want to answer, please.
Well, I'm going to answer this. I know Global Fund, when they're talking about PrEP, it's specifically to HIV. PAHO has the document, remind me again, Hortensia, what it's called, HIV prevention. HIV STI prevention for key population. And it's basically tracking what is happening, what are the prevention services that are being promoted. And one of the areas as it relates to PrEP is the testing and the counseling. Not only for, it's the testing not only for HIV as part as PrEP, because remember, as I said, if you look at the comprehensive package of service for PrEP, it includes testing of HIV, STIs, and a number of things. It's not just only giving the pills for PrEP. So, and that is the reason why I would recommend that countries look at the guidelines that was developed for the Caribbean, because that is within that context. Now, I know we're talking about what Global Fund will pay for. And I do know this is a challenge, because I know for some countries it is not being paid for, and it may be the country that is paying for the cost of the syphilis test, because syphilis may be free anyway in the health services, so that service is not really being paid for. So and this is why everything has to be contextualized as to what is happening in that country. And also remember, Global Fund does not pay for your full package of service. They will only pay for certain things. So we would have, rather than just looking at it in general, we would have to look at the context of that Global Fund project for the country. So that is my long and short response to your comment at this time. Thank you.
Thank you, Sandra. I just want to say that the WHO recommendation is testing, integration of testing, the syphilis, other diseases like hepatitis, because we have a guidance for elimination of the HIV, STI, and hepatitis. In order to PAHO adapt this recommendation of the for the implementation, we also recommend the integration of the testing. We don't have a multiplex test now for the three diseases. We only have in the strategic fund HIV syphilis dual test. And on my understanding, this on the portfolio of the Global Fund. But this is one difficult situation because the restriction of the fund situation. But maybe this discussion is for programmatic coordinators later. In the contextual setting, we recommend testing for syphilis, hepatitis, and HIV in the key population. And we address this issue later in our workshop, okay? I understand we are 15 minutes delayed. I ask kindly to our coordinator if we can move ahead and let the question to the discussion, because if not, we can address all the issues for today.
Yeah, just before you go to Hortense, I want to say just on this topic, because of the issue of rapid tests, we have HIV and syphilis rapid test, the dual test, it makes it much easier to test a person for HIV and syphilis at the same time. But as Hortense said, there's not a test that tests all three at the moment, but hopefully down the road. And Hortense, as you go through your presentation, there is a question that says, is PrEP and VCT counseling, is it the same? The long and short answer is no, but I will leave it to you that as you go through your presentation for you to factor that in as well. Yes, so over to you.
Just a
But
minute.
continue the doctor.
Yeah, so Dr. Hortensia, I actually have Dr. Shiftas, who should be up next. Yeah, so
Oh,
I
okay.
noted at least 2 questions in the chat. If we have time at the end of today's session, we can respond to them. However, if not, Dr. Hortensia or myself can respond via the chat. So I'd now like to invite Dr. Divya Shivdas, the National Care and Treatment Coordinator here at the National AIDS Program Secretariat, Ministry of Health, Guyana. And she is going to be covering an overview of oral PrEP, particularly looking at WHO guidelines on oral PrEP evidence and the evidence for oral PrEP, looking at the various target groups and basically the efficacy of PrEP medications being offered to our high-risk clients. So please allow me to hand over now to Dr. Shivdas.
Good afternoon, everyone. Thank you for those welcome remarks, Dr. Chin. Can you just confirm that you're hearing me and seeing my screen before we go on?
Yes. Yes, we can see the PowerPoint presentation and we can hear you.
Okay, great. One sec. Yes. Thank you again. I'm just going to
Uh,
turn off my camera
Sorry,
so that
doctor.
we can see a little back.
You change the mode and now we can see your PowerPoint presentation. You need to change them to the view, you know? You have the
Okay.
moderator view, your presentator view.
Are you seeing it now?
Mm, no.
No. My apologies, guys. Let me figure out. Is it okay now, Dr. Hortensia?
No, up on my side.
Still, oh my gosh.
We see it in the presenter view. You need to change. You are using a Mac?
Yes.
Mm. Okay, maybe isn't that with when you have the 3 points? Okay, now we can see.
Okay. All right. Just give me one. I'm trying to get my notes. I'm sorry about this. I think so. Let me see. All right. So sorry about that, guys. So thank you so much for including me in this conversation this afternoon on this very important topic. I think all of the speakers who've gone before me have already mentioned the fact that we're all really interested, and that's why we're here today. So my presentation is just an overview on the oral pre-exposure prophylaxis. I'm going to go a little bit into the WHO guidance, as well as some of the evidence that supports their recommendations. So my objectives are my objectives are stated here in the slide. I want to focus on allowing us to understand the importance of PrEP and its role in reducing new HIV infection. I want to revise the WHO guidance on oral PrEP, specifically the more recent recommendations that have been put forth, and I want to review some of the main evidence that supports the use of oral PrEP for preventing new HIV infections. So, currently, we are all here because we have one goal in common. We want to end HIV and AIDS as a public health threat by 2030. Most, or I think all of our governments have signed on to this goal. And what that means really is that we want to see a 90% reduction of new cases, as well as a 90% reduction of AIDS-related deaths when we compare with the 2010 values. What would happen? This diagram here, it basically shows us where we are right now and what's projected to happen if we keep going at the same pace, for lack of a better word, with our interventions and our response. The red dots, they basically tell us that the things that we're doing right now are not going to lead to elimination by 2010. For us to really put any kind of for us to move closer to that target, we really need to scale up all of our actions. And this is where the impact of the fast track approach comes in. It's basically where we're trying to do a grand scale up of all of our interventions as it relates to treatment as well as prevention initiatives. We're going to try to focus on zero discrimination. We want to remove stigma and all of the different barriers that patients really have when they try to access services or get HIV related care. This diagram here, it's just two little graphs that's telling us where we are right now. You can all see in both of we can focus on the one to the left first. It tells us how many new infections we have per year globally. You can see that in the early 2000s, we've had a significant spike in the new infections, but this has since been gradually decreasing. Since 2010, you'll be glad to hear that we've had a 40% decline in our new incidents. And if you look to the graph on the next side, you'll see that we've had about a 54% decline in HIV-related or AIDS-related deaths. This is great news, but it still means that there's work that we have to do for us to meet those targets. We're only a few years away from 2030, but we're not really close to the 90% decrease that we're looking for in either of these parameters. So it's really highlighting the fact that we need to really scale up our interventions. How are we planning to reach HIV elimination? There's no single strategy or intervention that's really going to take us where we need to be with HIV elimination. What I have outlined here is a series of strategies that need to work simultaneously closer to that goal. We need to first be able to diagnose persons with HIV as soon as possible, which means that we have to really scale up our testing and contact tracing and index testing for our patients. Treating. As soon as somebody is diagnosed with HIV, we need to be able to link them to care and have them achieve viral suppression through the use of antiretroviral therapy. For the prevention aspect, which is what I'm really going to go into a little bit more today, we have some really cool interventions, and I know they're not new interventions, but as Ms. Jones would have highlighted, that we really need to scale up our use of PrEP as well as PEP if we want to make a dent in the targets. So none of this is our interventions that should be only administered or available at health facilities. The WHO, as well as our national guidelines, they have all continuously tried to establish community participation, where the communities are really participating and being involved in all of these steps. So it's not just going to a facility, getting treatment, it's being having these interventions available at the community level as well to maximize the impact and the reach. So let's go into PrEP. What is PrEP? I was really glad to see that a lot of people indicated that they want to know more about it. But I'm sure that this is not something that's completely new to any health system or any country that's present on the call today. PrEP, as most of us may have an idea, is the use of antiretroviral medications by persons who are not infected with HIV, meaning they need to be HIV negative, and the intention is to reduce the risk of acquiring an HIV infection. So all of the data that we have and all of the guidelines and all of the bodies that really guide us on PrEP, the recommendation is that it should be taken consistently and as prescribed. And when this is done, it's been found that PrEP is highly effective in preventing HIV, and it can actually reduce the risk of HIV acquisition through sexual exposure by approximately 99%, which is a significant feat. So PrEP, as great as it is, there are some things that PrEP just won't do. It does not treat HIV. So a person cannot be HIV positive and taking PrEP. It does not prevent the acquisition of other STIs either, nor does it prevent pregnancy. So what does this mean? It means that PrEP should not really be a standalone measure. PrEP should be used in combination with other strategies that we have to prevent STIs in general. These include things like getting tested frequently, It includes condom use, use of lubricants, getting screened and tested for STIs, and using family planning, to make sure that the person is treated holistically and that the combination prevention methods would yield the maximum results. So over the years, there have been many, many different accomplishments and achievements in the realm of HIV prevention. Since 2012, when the first guidance on introducing PrEP as an additional prevention option came about. This basically laid the groundwork for later formal recommendations. To note, it wasn't until 2015 where the WHO actually started to recommend tenofovir-based oral PrEP that should be offered to anyone at substantial risk or ongoing substantial risk of acquiring HIV as an additional prevention choice. So this moved from previous guidelines beyond just a single population, a single high-risk population, generally the men who have sex with men population, and it extended the use in the general population. Anyone who has a substantial risk of contracting HIV was to be offered PrEP. And this was since 2015, so it's been about 10 years since this recommendation has been implemented or has been written into the guidelines. But as was reported earlier, we're still not seeing the uptake that we have expected to see by now. Over the years, a lot of different guidelines came about to build on this. They started to include different modalities of PrEP. The 211 PrEP or the event-driven PrEP was introduced in 2019 into the guidelines. And there are subsequent presentations that will go into this, so I wouldn't delve into it too much. So this was an additional option for adult men who have sex with men, so that they can, and it helped to foster adherence in this group as well. And since there have been many more recommendations that built on this premise, more recently, the 2022 guidelines that were brought out, they focused a lot on differentiated and simplified PrEP delivery in the communities. And we'll go into that in my next slide, or my next slide following this one. So the WHO 2015 recommendation, I just put this here because it was such everyone needs to know this. Oral PrEP should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of a combination prevention approach. So this is a strong recommendation based on high quality of evidence. So there's two things that are coming out of here. First, that everybody at a substantial risk of HIV should be offered PrEP. Not just men who have sex with men or persons who are perceived to generally have higher risk, such as key population groups, but general population as well. And secondly, that it should be part of a combination prevention approach, meaning not just PrEP. You're not just offering PrEP to a person who has a substantial risk, you're also counseling them on risk reduction methods, as well as other initiatives aimed at decreasing the transmission of STIs. So the updated guidelines from the WHO, these are some of the key points that have come out of that guidelines. So first and foremost, they advised on when to start and stop PrEP. Well, it should be highlighted as an addition here is that the event-driven or the 211 PrEP that you're going to learn about in a bit was now offered to all persons assigned male at birth, not just the MSM population that was previously taken into consideration for this approach. As it relates to kidney functioning monitoring, so the WHO actually they suggested this as an optional requirement and only in certain populations. So where it's available, sure, it's advised to have your kidney function monitoring done. But if a person is less than 30 years of age, or if they have no underlying kidney disease or any underlying comorbidities, they can actually go ahead and start PrEP without receiving results for a kidney test prior, which was, recommended in previous guidelines as well. So the new guidelines also strongly suggested that HBV and HCV, hepatitis B and C testing be done in the setting where PrEP is offered to provide linkages to treatment as required. And the use of self-testing kits is also brought up in this guidelines, which was great because it was recommended that it could be used as an additional testing option to complement HIV testing strategies for oral PrEP. So one of the main focus in this guidelines was on the differentiated PrEP service delivery. And this is not something that this is something that most persons would be aware of. Differentiated service delivery means that you use different approaches outside of the traditional health facility provision of care. So it's more a persons and community-centered approach where you really try to adapt the service needs to the needs of the people who are supposed to benefit from them. So it is intended to be more efficient and cost-effective and better use of healthcare resources because you really reach more people where they are instead of waiting for them to visit a facility. So the idea, like we said, is for you to take the services to the communities. You can do hello. Yeah, to take the services to the communities. There have also been cases where you can use virtual settings like we're doing right now, but you can use telehealth, for example, to provide the service in virtual and remote settings.
Doctor, you are mute.
Yeah. Oh, sorry about that. Sorry about that. Yes. So as I was saying, the WHO, they've been recommending that the services not necessarily be delivered by a doctor alone, as was the case previously. We're actually asking or recommending that different cadres of staff can provide the service to persons, including nurses, pharmacists, as the need may be. And even in the communities, there can be peer advocates or peer educators who can spearhead the provision of these services there. As it relates to the when aspect, they're moving more towards the use of multi-month drug dispensing for PrEP, just like we're doing for HIV care and treatment. And the reason for this is it makes adherence and regular follow-up with appointments even easier or more easy for the patients. And this has also been a very good initiative that helps to guarantee or better guarantee adherence. As it relates to the services that are offered, we already spoke that it should not be a standalone measure. Apart from other STI-related risk reduction methods or strategies that can be offered at the same time, there's also been a push to integrate HIV services, including PrEP services, into other family health or family clinic-related settings, such as vaccination drives, family planning clinics, and so on. So there are many countries that are really trying to do different approaches with PrEP delivery. And I don't think time permits, or we can go into some of those in a bit after the presentation would have concluded. So the evidence for oral PrEP. So most persons who are here would know that the OECS has recently developed guidelines on PrEP. These guidelines were developed based on reviews of several studies that I've highlighted on this slide. And while we're not going to go into detail with all of them, there are a few that I really want to highlight. All of these studies that are listed in this little graph, there have been landmark studies and they've really informed the guidelines that we have in existence both the national guidelines that you may be accustomed to in your settings, as well as international guidelines that have been put forward by governing bodies like the WHO and the CDC. So these guidelines, what these studies rather, what they have in common is that they've shown consistently that PrEP, oral PrEP, is effective in reducing HIV acquisition, regardless of the age, gender, and sexual orientation or practices of the person using it. It's been shown to be safe for use in a wide range of population groups, and there have not been any significant associations with biological or behavioral risk. As PrEP was first introduced, there was a lot of concern that, providing PrEP may increase the risky behaviors of the persons using it. But what the studies show is actually the opposite, that there's no effect or there's no increase in risky behaviors. And that's because generally it's a combination prevention strategy, not just PrEP, but different types of prevention strategies are being combined into that setting. Okay, so just to go into a few studies. The first study I really want to highlight is the IPEX trial. This was a study that was done mainly amongst the MSM and transgender women, and it was conducted in 6 countries: Peru, Ecuador, Brazil, South Africa, Thailand, and the USA. It was a randomized, double-blind, placebo-controlled trial, and the 2 arms were the placebo arm and the arm of persons who were offered daily PrEP that we know as Truvada. It's now called FTC TDF. So it was the placebo versus the Truvada group. So it was a really big study. There were about 2,500 HIV negative persons who enrolled. And what they found was that there was a 4% overall reduction in HIV incidence. What does this mean when I say that there's a reduction in overall HIV incidence? So you'll often see that in trial, the results are reported as PrEP efficacy. What this means is the proportionate reduction in HIV infections compared to the placebo group. So this first study, 36 HIV infections came from the Truvada group versus 64 from the placebo group. So this translated to a 44% overall reduction. But what was even more promising is that the persons or the individuals who had high adherence, they've actually been able to track that they've had more than 90% protection with the drug. So this has been one of the landmark studies. The second study I will speak briefly on is the partner study. This was one of the earlier studies as well, and it was done amongst HIV serodiscordant heterosexual couples in Kenya and Uganda. So this again was a randomized double-blind study with 3 arms. They looked at the placebo group. You had a group with tenofovir alone, and then you had a group with the tenofovir, emtricitabine, or the Truvada combination. So this again, it was a pretty big group. There were about 4,700 couples, and they were followed for about 3 years. So what they found is that with the TDF alone group, this is the tenofovir alone, there was a 67% reduction in HIV acquisition. In the Truvada group, which is the TDF FTC, there was a 75% reduction in the HIV acquisition, which is great. These are all really promising results. However, just like the previous IPEX study that we spoke of, the persons who had high adherence, they've seen over 85% risk reduction, which again is a pretty promising results as well. Okay, so we can speak a little bit about a PROUD study. This is one of the more famous studies that that most persons may have heard about. It was conducted in men who have sex with men and transgender women in England. It was an open label study, and the arms were persons who were started on ART immediately versus person who had deferred initiation of ART. So what they found is persons who started ART immediately at the follow-up point, they had an 86% reduction in HIV infections. And there was no other increase in other STIs or any other evidence of any increased risky behavior, which was what a lot of persons had expressed concern about at this time. So this again had really good results, and
Did
Um,
we lose the moderator?
yeah, we lost the audio. Doctor, we can see your presentation. I don't know, we lose you. I think we
She's
lost.
muted.
I'm sorry, I got disconnected there. The
Okay.
Wi-Fi is a little sketchy here. I'm sorry. So do you guys hear when I went into the PROUD study or?
Yes.
Okay. All right. So the hypergay study. This is one of the more famous studies that were done, and it was done around 2015. It was done amongst high-risk men who have sex with men in France and Canada. This is the first time that they really studied the event-driven or the on-demand, PrEP on demand, as we call it, the 2-1-1 PrEP. So what this study found is that there was an 86% risk reduction in persons who used the on-demand PrEP, which was really a really good and promising result. So it was found that the on-demand PrEP is highly effective for high-risk men who have sex with men with frequent sexual activity. So I think the presentation that follows me will go into the different modalities, but I just want to highlight that the on-demand PrEP is just for biological males, men who have sex with men, or transgender women. So in all of these studies, one of the key things that came about is that adherence is important. A few of the studies that I told you about, they actually looked at what the adherence was in the overall group versus what the risk reduction was in the group of persons who were actually adherent. And you would note that there has been a significant or notable difference, highlighting the importance of adherence in this strategy. So this table that follows here, it just tells us a little bit of what I said already. The study, as you can see, generally, if there's a reported, for example, with the first PrEP study, there's a 44% efficacy with the PrEP that was found in this report. However, when they looked at the percentage of samples who actually had detectable tenofovir levels, which means, or it was assumed to mean that the persons were adherent to the medication, you found that the efficacy went up significantly, almost twofold, which is has been consistent with other subsequent studies as well that are listed here. The Partners PrEP study, the TDF2, as well as the Bangkok IDU, which was actually one of the first studies that were done in injection drug users. So you'd notice that with the highlighted text, the highlighted in red, adherence really makes a big difference. So you would see, for example, in the partner study, the adherence with persons, the efficacy with persons who um, were on the Truvada was 75% in the overall group. However, when you look at the persons who were actually adherent to the drug and they had detectable levels of Truvada in their bodies, the efficacy went up to 90%. This again just underscores the importance of adherence in PrEP. The last two studies were two that were done in women. But what was found is that these studies were both discontinued, and the reason is because the uptake or the adherence was not great, so the studies were not actually producing any substantial res- any substantial reduction in cases. So it was discontinued early, and it's mainly on account of poor adherence and uptake by the participants. The Discover trial is one of the newer trials that we can talk a little bit about. And up until this point, we had been talking about Truvada, which is the tenofovir DF. So this drug has been what was used by what was recommended by all of the governing bodies. And it was not until this study came about that we actually have some evidence where that drug was compared with the Descovy, which is a combination of tenofovir alafenamide and emtricitabine. So the difference between these two drugs, they're very similar. There are a few key differences as it relates to the effect on the kidneys as well as the how it affects bone density and so on. But generally, they're both very similar. The Discover trial, what they wanted to do was to check to see if both of these drugs had comparable effects. It was actually the largest PrEP clinical trials, and it engaged over 5,300 participants. It was a randomized, active controlled, double-blind study of HIV seronegative men who have sex with men who have sex with men, and transgender women. And they used daily Descovy or the tenofovir alafenamide and emtricitabine combination, highlighted in the green, and they compared it with the tenofovir, the Truvada, which is a combination of the tenofovir DF and the emtricitabine. So the Truvada, we're accustomed to that. That's the one that we know about. But they were comparing to see what the differences would be. So what were the differences? After about 96 weeks, which was the end point for this study, there were very promising results. They actually found that the I don't know if I can highlight here. Okay, I don't think I can highlight. At the primary analysis, the HIV incidence in the group that was using the Descovy, which is the tenofovir alafenamide combination, was 0.16 per 100 person years. And the persons who were actually using the Truvada was 0.34 per 100 person years. What is it saying? Just that it's very similar. And because of that, it was actually now being considered as an alternative for persons who are interested in PrEP, and specifically though for men who have sex with men or transgender women, which is the population in which the study was conducted. Women were not involved in this study, so that recommendation only stands for those population groups at this time. So we have the two options that we can use for PrEP at this time: the Truvada and the Descovy. I think I don't think we'll go into a lot of this, but this here is a slide that summarizes basically who can use this medication as well as what the safety concerns may be. So with the Truvada, we can use it in men who have sex with men and transgender women. We can use it in heterosexuals. We can also use it in persons who inject drugs. However, the Descovy, we can only use for men who have sex with men and transgender women for now. The effectiveness, as you can see in this diagram, it's similar. It's comparable with both groups, with both medications, as well as the safety concerns are similar. However, there are a few key things that you might want to highlight. So if you look at in the middle where it says safety at 48 weeks, you see that the effect on the kidneys, which is the estimated GFR, it is more forgiving with the Descovy. as well as the effect on the hip bone density marrow. So if you have patients who do have these concerns, you may want to consider the Descovy if it's available to you, as opposed to the Truvada. And they're both similarly almost equally effective. There is a little bit of a note here as it relates to the effect on the lipids, the LDL, as well as the body weight, which favors the Truvada as opposed to the Descovy. So these are just a few things that you can have in mind when you're starting a patient on PrEP. If they have kidney issues, you're more than likely, you may want to favor the Descovy as opposed to the Truvada. And if you have a patient with, body weight issues or lipid profile, underlying conditions, you may favor the Truvada. Just note that based on the studies, both of them are similarly or almost equally effective at preventing HIV. How much time I have? Okay. So Dr. Chin says I have 5 minutes more. I'll just go into, we've talked a lot about the Truvada and the Descovy. I want to leave some time for questions, so I won't go into all of these other slides that I have. But just this last one here, which speaks on the HIV treatment being used as prevention as well. We know that HIV treatment as prevention is not a new concept. It's been around since the advent of art. And this was a study that was done in Australia. It's called the Taipan study. They really wanted to assess whether HIV treatment as prevention could reduce HIV incidence at the population level amongst gay, bisexual, and other men who have sex with men there. So they found that what happened is as the population viral load suppression increases, so does the reduction in the incidence of HIV. So this was actually a pretty promising result. It said that for every 1% increase in viral load suppression that the country had, there was a 6% reduction in the incidence. So this is something that we should also keep in mind when we talk about, prevention of HIV using medication. Let's see. I'll skip through this in the interest of time. And okay, so this is an article that I came across. It was talking about HIV transmission being virtually eliminated in inner Sydney, Australia. And this has been great. They found that there have been about an 88% reduction in new HIV cases when compared to 2010. And the reasons for this is because they've really had a scale up of the PrEP program. They've made the PrEP services available to many different clinics across the country. And because of that, combined with the linkage to care and rapid ART initiation, they've really managed to get a grasp on it in this part of Australia. So what does this mean? It means that it's not a single thing that is really going to get you to elimination or reduction in cases. You have your PrEP, but at the same time, you got to focus on, you got to include other prevention strategies like your risk reduction, your treatment as prevention as well, because all of these things combined, that is what's going to take us to the targets that we're hoping to achieve by 2030. So this here is a little diagram that shows you what the impact has been so far as PrEP access has been scaled up in some major cities in the world. So we've had a scale up in San Francisco, which between the years of 2012 and 2016, they really ramped up their PrEP services accessibility and uptake has been good. And they've seen a 51% reduction in new cases amongst PrEP users and non-users combined. So similarly in London, Seattle, and Sydney, you're seeing a lot of notable reductions in new cases, and it's because of the scale up interventions that they've really been working on. And this is not just PrEP, it's and PEP and other post-exposure prevention prophylaxis that you're going to go into later, but just to show that, you know, the PrEP is making a difference in these places. And I know for sure that it's going to make a difference in the Caribbean once we start to really push its scale up as well. So just to conclude, PrEP is a great opportunity to reduce new infections in the Caribbean, and we can actually reach our targets once we use this in addition to the other initiatives that we've already been really pushing. There's an abundance of evidence that guide international and national standards of practice, and as we've seen, the effectiveness of PrEP in reducing new infections has been widely proved by numerous randomized control studies. Just to note, it's not here, but adherence to these treatments are key, and it does make a big difference in the overall patient outcome for the service. All right, so for acknowledgements, I just want to acknowledge Dr. Shanti Singh, who's kindly allowed me to use some of her slides. And these are some references that I used to prepare this. I want to say thank you again for the opportunity to present this afternoon, and I'll gladly take any questions that you would have. Yes.
Dr. Kishan, you will continue with the moderation?
Yes, Dr. Hortensia, we actually invited any questions, but we don't notice any in the chat. Yeah, we don't notice any in the chat. And none of the participants have their hands up. So thank you very much to Dr. Shivdas for her excellent presentation on the WHO guidelines and the evidence surrounding oral PrEP medication. Definitely, she has caused us to do a bit of critical thinking as it relates to how we apply these guidelines into practice. As we are aware, for HIV prevention today, one of the most powerful tools that we have is oral PrEP. So evidence-based data has shaped our guidelines and definitely how effective our practice is as it relates to providing PrEP services to key populations and other populations or communities that are at risk. So being familiar with those guidelines is extremely important, not only for healthcare providers, but also for our program planners. So again, thank you to Dr. Shivdas for her presentation. And now, I know we're looking at the time, but I would now like to again invite Dr. Hortensia for her to give a presentation on PrEP, specifically looking at PrEP initiation and follow-up, side effects, PrEP modalities, looking a little bit also at NPEP and PrEP for acute HIV, and touching a bit also rather on acute HIV infection. So Dr. Hortensia, over to you.
Thank you, Dr. Hisha. I want to say thank you to all the 150 persons that we are here. I know that it's tired to be in a virtual training. Please give us a moment. I want to ask you if you can give us a reaction, a heart, an applause to Dr. Divya, please, in virtual mode, to just to know that you are there, please. Thank you, thank you. You are awake. That is very good. It's a motivation for us because we need to know that you are there. And please, if you have questions, and this is the time for do it, put it in the chat. Dr. Keisha is she can put the question and we can answer If we not have time today, we have tomorrow. And PET we talk tomorrow more specifically because I want to concentrate today in PrEP, in implementation and initiation and follow-up. Thank you for your reaction. Please, if you have questions during the PowerPoint presentation, don't hesitate in put it in the chat, okay? I need someone confirm that you can see my PowerPoint presentation in a presentation mode. I need verbal because I just have one screen.
We can see. Yes, we can see.
We see, according to the evidence, that PrEP implementation is associated with a decrease in HIV incidence. We have studies published that, for example, San Francisco, Seattle, London have reduction in the new HIV incidence, and Sydney achieved now in 2018 the 88 reduction in new HIV infections and declared in the IIS in 2023, they achieved the target for elimination of HIV in inner Australia, in inner Sydney in Australia. We trying to do this exercise in our region because you know that UNAIDS report said that the new HIV infection are not decreasing in the LAC region, but you know in the Caribbean region the new HIV infection are reducing better than in the Latin American countries. We tomorrow I will present some of the data that we have in our region. Today, I want to concentrate in the concept of a person-centered HIV prevention and care continuum. Someone asked if the voluntary counseling and testing is the same as PrEP. I need to say maybe it's not the same because PrEP is pre-exposure prophylaxis, but we need to do the voluntary counseling testing for open the continuum that prevention and care continuum in order to know what is the HIV status for the person, for the client, you know. We are trying to expand the concept that the HIV rapid test is the door for the entrance to the HIV prevention and care continuum. Every HIV test have a result, can be reactive or can be not reactive. And the happen is outdated way of thinking is HIV reactive need to confirmation and linkage to the algorithm test and initiate treatment, but the person who received the non-reactive result, we normally said, okay, coming back in 3 months, use some condom, behavior well, or something like that, no? With the evidence that doctor present, that we know that pre-exposure prophylaxis is a very effective intervention for prevent HIV acquisition. Actually, the oral PrEP can achieve more than 90% of effectiveness in the context of clinical trials for prevent HIV infections. And in the implementation studies, we also found an effectiveness when we combine efficacy and compliance, we can reach more than 86% of prevention of HIV acquisition. That means that if we have a person that has a non-reactive HIV rapid test, we need to make a risk of acquisition evaluation. Maybe the appropriate word is not evaluation, but we need to have a talk with our client and know why is the person making the rapid HIV test. It's because he or she has a sexual encounter without condom. Is because he was assaulted. Is because this is a routinary test. Is because the partner is HIV positive or is not suppressed or is not in treatment. We need to talk with the people and we need to offer information at this moment. If we have a non-reactive HIV rapid test, we need to evaluate if this person is on risk of HIV acquisition, and we also need to know if this person have sex or exposition to HIV beyond the 72 hours or within the 72 hours in order to offer pre-exposure prophylaxis or post-exposure prophylaxis, because post-exposure prophylaxis is an intervention that is approved for WHO recommendation more than 10 years ago and is very useful, but our countries is just applying in the occupational context or in the assault context. But now the WHO recommendation said that we need to open the access to the people for receive non-occupational post-exposure prophylaxis in order to enhance the probabilities to prevent HIV. And this that you can see is our concept for person-centered HIV prevention and care continuum that we're trying to work with the countries. That means we need to know about risk and vulnerability. We know risk is the possibility to have a damage, and the vulnerability is all the conditions that put you at higher risk. We know a person and our epidemic is a concentrated epidemic, and we know the key population has increased risk of acquiring HIV and other STIs, increased situation of vulnerability, and all these behavioral and social and legal issues have a role in the transmission of HIV, viral hepatitis, and STIs. What person is eligible for PrEP? What are the considerations? The first and the only must, I need to say the only is the person must be HIV negative. Pre-exposure prophylaxis is not for HIV positive people, okay? The person must need to be HIV negative. And also, the person is important not have suspicion of acute HIV infection, have substantial risk of acquiring HIV, and no contraindication to receive the PrEP medication. One of the consideration for the tool for the implementation of HIV pre-exposure prophylaxis is the willingness to adhere to PrEP and periodic HIV testing. And we need to ask to the people, we can force the people to receive PrEP. This need to be a voluntarily action for their health. Other indication for the PrEP use is when the sexual partner has with one or more risk factor for HIV, the sexual partner of the person, of in the past use for post-exposure prophylaxis. For that reason, we have a road through post-exposure prophylaxis to PrEP. If one person receives post-exposure prophylaxis, if the end of the month of treatment, we need to take a test for HIV, and if the person is negative, we need to offer the opportunity to receive pre-exposure prophylaxis if the person wanted. And and the WHO makes some amendment to the guidance, and in this point of substantial risk of acquiring HIV, and the guidance said if the person requests PrEP, we need to consider this situation like a substantial risk of acquiring HIV. Why? Because it's not so easy in the first consultation for one person, if this is the first visit or if it's the first moment that I know in this physician, nurse, or counselor said, I am gay, I have 10 partner, I have 50 partner. This is a difficult situation to explain in the first encounter. For that reason, if the person coming to us requesting PrEP, we need to make the HIV test, and if the person is HIV negative, we need to talk with the person and try to know what is asking for PrEP, but we need to consider this is a risk factor to HIV acquisition. Also, we need to consider in the substantial risk of acquiring HIV, in the center of the risk are the people with a partner who was HIV positive and not virologically suppressed. But we need also to know the concept that indetectable is equal to intransmissible, because if the person has HIV but received treatment and is virologically suppressed, the partner doesn't have risk to acquiring HIV from this person. But if the person has another or multiple partners, is in risk. Okay, people with indication for PrEP that we talked in the previous slide, and also we need to consider people in high prevalence group or communities. And then at the end of the circle, the general population. We need to evaluate the risk, sexual practice, and also the injection practice. And we need to put the necessities of the person in the center. How to address the vulnerability? Because this is an issue that is not so easy to talk in the clinical settings. Maybe you have a lot of patients, maybe you have not enough privacy, but you need to find a way to ask. For example, have you received money, housing, food, or gift in exchange for sex? uh, Maybe not direct, but we develop some abilities or techniques to talk with the people. Not necessarily like a checklist, because if it's not an exam, it's not an evaluation, it needs to be a conversation. But you need to know if this person have been forced to have sex against their will, it was physically assault or including assault by a sexual partner, if this person inject drugs or hormone or using shared equipment, for example, if this person use a syringe and share syringe, not necessarily for drugs but for other things, we need to know. Also, if they use recreational or psychoactive drugs, if the person been forced to leave their home or move to a new place, probably, for example, when the person coming for a setting to higher prevalence of HIV, of this person loss of source of income or left school earlier than their plan. All these things that can help us to address the vulnerability. The contraindication for the oral PrEP use, the first and the most important is the person HIV positive. If this person have an HIV positive test, can receive oral PrEP. Is contraindicated or use oral PrEP for a person who is HIV. This person has a potential exposure to HIV in the past 72 hours. This person can receive oral PrEP. This person need to be evaluated and counseling for post-exposure prophylaxis. If the person has a sign of acute HIV infection, for example, fever, headache, rash, um, joint pain. When I said fever, headache, and rash, this is like a dengue definition case. I know this can be syphilis, this can be Zika, this can be chikungunya. But if we have the knowledge of a sexual encounter between the 7 days, previous 7 days, we need to have suspicion of acute HIV infection. And for example, if you are suspicious dengue, but dengue is negative, Zika is negative, chikungunya is negative, well, maybe you need to ask for this person to have a sexual encounter or have the suspicious for HIV acute infections. Also, it's contraindicated if the person is unwilling or have inability to commit to effectively using oral PrEP. I know this is very difficult to decide in the first consultation. The best advice is not force to anyone to take PrEP. In the case of allergy or hypersensitivity, and if we know the person has kidney function impairment, that means estimate glomerular filtration rate under 60 milliliters per minute per 1.73 meters square, on a clearance of creatinine less than 60 milliliters per minute. Doctor, I mentioned before that the studies of Discovery trial, she talks about the tenofovir alafenamide. Unfortunately, we don't have a generic version for tenofovir alafenamide combined with entrectinib, and all this problem for access make that WHO is not recommending tenofovir alafenamide like a first option or a recommended option for PrEP, but make some note for the countries if they have person to have a kidney impairment and need PrEP, they can be considered tenofovir alafenamide. But we don't have we have in the strategic fund tenofovir alafenamide, but just for treatment and just separate for the entrectinib. We don't have the combination. This is more difficult for the people take more pill that they usually. In case of the start to, or in the case of the consultation for this conversation in an oral PrEP counseling, we need to address the sexual practice, the alcohol and drug use, the plan for preventing HIV and other STIs, the mental health status, especially when we are talking with the youngest, because we need to know the most of the new HIV infection are concentrated in young population between 19 and 24 years, and also we have new HIV infection between 15 and 19 years. And this is a dramatic case because if we have a prevention intervention, we need to use it in the package of combination prevention HIV that include educational, condom, STI screening, HIV testing, pre-exposure prophylaxis, and etc., etc. We need to take in consideration the willingness to take oral PrEP, and also we need to ask to the person if the experience of gender-based violence, including intimate partner violence, because in some cases women can need PrEP, or also male can need PrEP, even though they also have one partner. But if the person can negotiate the condom and is in a situation of violence, sexual violence, needs to consider the use of PrEP. Also, in this counseling, we need to explore the contraceptive needs. It's a reality if you want to do HIV prevention, you must talk about sex with your client. If you are not if you don't have the willingness to talk about sex, it is difficult to talk about PrEP. And the PrEP counseling should be based on the following right to health-based principles, need to be client-driven and person-centered, based on their need, resources, and preference, be based on a foundation of respect and including an open, honest relationship between provider and client. We need to validate and normalize client concern because it's not our concern, it's not our judge, it's not our sexual preference, it's the client concern. Seek to affirm and encourage client effort and not be prescriptive or judgmental. And is it very important? We need to leave our judgmental, our perceptions out of the clinical room of the setting of that we are talking with our client. We need to focus on identify small wins and achievable next steps in reducing potential exposure and or making effective use easier. We need to make it easy for the people, not harder. And we need to include some contingency planning. For example, if they forgot one pill, of in case they lost the pills, of in case, if, for example, in the case of the young people, if they are not talking with their parents about sex, but they are having sex and they want to receive protections, and we give them the PrEP. And for example, if the parent found the pills, how address these issues, no? Maybe change the bottle. Maybe the bottle needs to not label something that seems like a very easy things, but it's not so easy when we are in front of the patient, in front of the client, to make it easy the situation. Also, we need to promote choice among available options. Uh, we talking about the WHO recommendation, and tomorrow we are talking about the new WHO recommendations, and we will know that all the portfolio that we have for PrEP, oral PrEP, and injectable PrEP. Some tips that are important or helpful to talk about sex. The first one is assess your own comfort discussing sex because you need to talk about sex if you want to talk about HIV prevention. Establish a rapport before asking sensitive questions, not checklists, remember. Avoid making assumptions. Example, age, appearance, marital status. I was in the clinic setting until how many years? 8 years. I made clinical practice for more than 14 years. And I know when we can make a mistake making assumptions. And this is very important to not do it. We use neutral and inclusive terms like a partner and pay attention to your body language and posture when you are talking with the people. What are the options in PrEP now? Because I update this slide for you guys because this was concentrated in oral PrEP, but now we have different options. The first thing that we need to make be sure that the person is HIV negative. If was exposed to HIV in the previous 72 hours, the person is not candidate to PrEP. We need to offer post-exposure prophylaxis. Then we need to be sure that we doesn't have suspicion of acute HIV infections. And if we have symptom of acute viral syndrome, it's preferable defer PrEP for 4 weeks and retest for HIV and then take a decision. Okay? What are the offer? For MSM, we have daily PrEP, event-driven PrEP, long-acting injectable, including cabotegravir and lenacapavir that are included in the WHO recommendation. For transgender women that are not receiving hormones or this therapy hormone, this group can receive daily PrEP, event-driven PrEP, and also long-acting injectable, including cabotegravir if they don't have implant, because cabotegravir is an intramuscular injections and needs a very deep tissues, and when they have some prosthetic, it can be used. And lenacapavir is subcutaneous and include for transgender not receive hormone, and also for cisgender women. In the case of cisgender women, we also have the daily PrEP oral. The women can use event-driven PrEP, even though the transgender women who are receiving hormones, they can use event-driven PrEP. But for cisgender women, we have the dapivirine vaginal ring. It's a very low efficacy. I have a slide for you, but it's included in the offer for PrEP in sexual active persons. Before starting PrEP, it's important to know the serological status for HIV, and I will repeat this so many times today and tomorrow. PrEP is for HIV negative person. If the person has HIV or has a result for reactive or positive HIV test, we can give them PrEP. Okay? We need to use or we need to test for the serum creatinine, the antigens for hepatitis B, and also for hepatitis C, and for syphilis, and other STI screening and the pregnancy test. But all this result can delay the start of PrEP. Waiting for these results should not delay the initiation of PrEP, because we can take the sample and we analyze later and give the appropriate treatment or response accordingly to the result in the next visit. The only laboratory result that we need to know in order to start PrEP is the HIV test. What antiretroviral are used for PrEP now or are approved for PrEP? We have lamivudine, entrucitabine, tenofovir disoproxil fumarate, tenofovir alafenamide, also dapivirine for vaginal ring, cabotegravir for intramuscular injection, and lenacapavir was approved in the July 14, 2025 for prevention in different populations, like I mentioned before. For the PrEP prescription, it's very important the client who will use oral PrEP daily or even driven could be prescribed a single bottle in the first visit, okay, for 1 month, and the next follow-up visit needs to be in between 1 month. Sometimes it's important to give them 2 bottles, but we need to be sure that the person came or we make the HIV test 1 month after the start the PrEP. Based on the client needs and preference, client could also be provided with multiple bottles, but this is our country decision. The evidence said that client using oral PrEP who has some medication supply in reserve tend to show better effective use because it's better that they have more pills instead to have stock out, personal stock out for medicines and discontinued the PrEP just because the person maybe can go to the next appointment to HIV test. Okay, for compliance, maybe we need to be not so strict with the number of bottles that we give to the people. And when it's possible, follow-up visits should be coordinated with visit for other service. For example, I don't know, Papa Nicolau, or if the person is diabetic or have hypertension. We try to not make the person come many times to receive the PrEP. Okay. I will put this short video for those that is the first training for PrEP because we need to know how does PrEP work, because this is a question that I make so many times to the physician, to the nurses, to the counseling, to the community worker, and receive so many different answers. And we use this short video to show how does PrEP work. I think in the beginning I put the sound. Please let me know if you hear well or if I need to share the screen again, okay?
There under the pecan tree, as she did countless times, that day, my mother told me stories.
If you're like most people, you may not realize there are many choices for HIV-negative people to help prevent HIV. One highly effective method is PrEP, which stands for Pre-Exposure Prophylaxis.
Do you hear? Can you hear me?
Yes.
I'm sorry. I'm trying to put it in complete screen, but my computer is against me. Why? Okay. She can win. Now.
Prophylaxis. It involves taking a prescription pill that contains 2 medications on an ongoing basis. When taken as prescribed, PrEP is highly effective at preventing HIV. PrEP is for anyone who is HIV negative and at ongoing risk for HIV from sex or drug use. It can be used by people of all genders and sexual orientations. PrEP is safe and usually well tolerated, and most people report no side effects at all. The cost of PrEP may be covered by your private healthcare plan or public health insurance. So how does PrEP prevent HIV transmission? Let's start with how HIV infection happens. HIV typically enters the body through unprotected sex or sharing injection drug use equipment. After HIV has entered the body, it targets the CD4 cells in the immune system and begins to replicate within them, creating millions of copies of itself. These copies then go.
You are not seeing the video? Sorry.
No, just the audio.
Audio is playing, but we're not able to see the actual video.
Okay. Let me share. Optimize. And now you can see the video? You can see it?
Yes.
You may not realize there are
And you can hear.
Yes, we're getting
many choices for HIV-negative people to help prevent HIV. One highly effective method is PrEP, which stands for Pre-Exposure Prophylaxis. It involves taking a prescription pill that contains 2 medications on an ongoing basis. When taken as prescribed, PrEP is highly effective at preventing HIV. PrEP is for anyone who is HIV negative and at ongoing risk for HIV from sex or drug use. It can be used by people of all genders and sexual orientations. PrEP is safe and usually well tolerated, and most people report no side effects at all. The cost of PrEP may be covered by your private healthcare plan or public health insurance. So how does PrEP prevent HIV transmission? Let's start with how HIV infection happens. HIV typically enters the body through unprotected sex or sharing injection drug use equipment. After HIV has entered the body, it targets the CD4 cells in the immune system and begins to replicate within them, creating millions of copies of itself. These copies then go out into the body and find more CD4 cells and use them to make even more copies. The immune system tries to stop the cells from multiplying, but if the immune cells can't keep up, the HIV infection spreads to other parts of the body. At this stage, the infection becomes permanent. Now, back to how PrEP prevents HIV. When a person starts taking PrEP, the drugs reach high concentrations in the places where HIV can enter the body, such as the bloodstream, genital, and rectal tissues. The drugs prevent HIV from making copies of itself in CD4 cells. Since HIV can't replicate, the immune system can clear it from the body, preventing a permanent infection. This is why it is so important to take PrEP as prescribed, to ensure there is enough of the drugs in your body to stop HIV from replicating. When a person takes PrEP as prescribed, it is extremely rare for HIV infection to happen. If you think PrEP might be a good option for you, be sure to speak to your healthcare provider or your local HIV organization to learn more.
Okay, I'm trying to coming back to my PowerPoint presentation. I'm sorry, that is okay. You will have this link available for you and can continue if you want to see it different times, you can do it. The PrEP is safe and without major adverse events. The most important or most reported common side effects are nausea, flatulence, and headaches. This is a systematic review from different meta-analysis, and the principal adverse event was compared with the placebo, and because this was on the different control studies, demonstrate that PrEP is safe, and nausea and gastrointestinal symptoms was the very most important adverse effects. We can have the start-up syndrome, that is like these gastrointestinal symptoms. The use of over-counter medication for common side effects shall be discussed, like I don't know, some nausea medication or some gastrointestinal, accordingly to the country. And the person should also be consulted about signs or symptoms that
Hello?
indicate. Sir? You can see the presentation?
We can see it
Okay, and you can hear me?
very well.
Okay, thank you. It's important to explain to the client some situation that can be urgency, like acute renal injury or acute HIV infection. We need to talk about this situation with the client in the case, for example, no compliance with the medication for pre-exposure prophylaxis. We need to explain the symptoms for HIV acute infection, and the person need to be aware. Also, you can find this in this link, the interaction for oral PrEP drugs. Especially the most important is with the non-steroid anti-inflammatories, like ibuprofen or something like over-the-counter medication. We need to offer counseling to the people to try to avoid the use of NSAIDs because we can increase the risk for the kidney for the person. We can offer, according to WHO recommendation, according to the slide that I present to you, daily PrEP or event-driven PrEP or on-demand PrEP, that is the same, vaginal ring, and also long-acting injectable. In the case of event-driven PrEP or 2+1+1, we need to give the information for the client that the dosage for the in case of use event driven it's at least between the 2 hours before the intercourse and the person needs to take two pills in the day one before the sexual intercourse and then need to take one pill 24 hours after of the sexual intercourse and then another pill in the day 3 24 hours after the second days. That means this person needs to be very strict with the time to take the pills and also need to have the capacity to plan the sexual intercourse. If, for example, the person has for tomorrow for 12 and the noon, at least need to take two pills at least 10 a.m. or 24 hours before, can be today. If the sexual intercourse is tomorrow, 12 noon, then needs to take one pill on Saturday. No, because today is Wednesday, Thursday. Needs to take one pill Friday at noon and another pill Saturday at noon. If this person will have another intercourse Sunday, this is can be happening and need to take another pill and it's probably this person can beneficiate more than daily oral PrEP. But if this person have one sexual intercourse at a month, can easily use event-driven PrEP or on-demand PrEP. We have evidence and the no difference between oral daily PrEP and event-driven PrEP because they have a clinical studies, case control to compare tenofovir and tricitabine daily and on demand, and it was no difference between the populations. Have some advantage and benefit for event-driven PrEP. One of the advantages, the flexibility, choice, and convenience for people who may be at in high HIV risk for brief period or have sex infrequently, not daily, or not so many times a day, is adaptable to season of risk. Also is less pill burden, less toxicity, reduced costs, because even in the programmatic way, I can give one bottle for the person if the person who want to use event-driven PrEP, and probably this person not use all the bottle. We need to talk very clear with the person, and it probably has better compliance if we talk and give all the information because I see so many clients that are receiving daily PrEP, but they don't have sex every day. Sometimes they have sex once a month, but this is a very high risk sexual intercourse because maybe it's an orgy or maybe it's a with drugs or a party, and we need to be aware of this circumstance. Some disadvantage is need some planning before sex. Remember to take post-sex dose. That is very important in case of party. And probably the client will ask I can take this pill with alcohol? It is a very common question. And the best answer that I can give is better to have the pill with alcohol than HIV. And in some adolescents may need more support to adopt and adhere to 2+1+1. Uh, Event-driven PrEP can be used to prevent sexual acquisition of HIV by cisgender men and trans and gender diverse people assigned male at birth who are not taking exogenous estradiol-based hormone. That is very important. And we need to consider also the hepatitis B infection is not a contraindication for event-driven PrEP. Okay. Some logistic in case of event-driven and oral PrEP can be interchangeable because some people can pass for event-driven to daily PrEP, and then if the season risk change to less risk, change to daily PrEP to event-driven PrEP. That is very common, and that is included in the new guideline. It's better that we are flexible for the person to can change from the daily PrEP to event-driven accordingly to the risk. Event-driven PrEP is safe and highly effective in reducing HIV infection, and it's an alternative to daily PrEP for males and non-binary people who has assigned male sex at birth. It's not for all, but maybe more feasible for many in some setting. It's necessarily to give them education and support for both for daily and event-driven PrEP, but it's necessary to give them choices to the people because the people need to be part of the decision. And HIV testing is recommended as usual regardless of dosing schedule. Okay. In case of dapivirine, we have also dapivirine in our WHO recommendation, but we doesn't have any country in our region that are using the dapivirine. The only country that include the dapivirine in the guideline is Colombia in Latin America. So many women, cisgender women, ask for the offer to the option for PrEP. Global Fund is supporting some countries to give them some donation, but the truth is new presentation for the dapivirine ring is coming because the presentation that we have now is a silicone ring with the 25 milligram of dapivirine that we need to use every 4 weeks, and the dapivirine ring need to be inside of the vagina. They not have significant adverse effect and no impact in the pregnancy, also in the resistance, but the efficacy is very low, at least like a 30% of efficacy. And we are waiting for the new dapivirine ring that will be for 3 months and trying to know the data that if the efficacy is better than the have one, because we need to combine this dapivirine ring with other preventive measure for the low relatively efficacy. Another option or modalities for PrEP is cabotegravir. It's a second generation INSTI. It's analog for dolutegravir. Have a half-life elimination at least like 12 weeks. We need to use cabotegravir shot every 2 months intramuscular. The dose is 600 milligram. The principal adverse event is effect is pain. The injection is very painful. Even though we have the cabotegravir recommendation in 2022, today, August 2025, we doesn't have generic formulation for Latin America and the Caribbean, and we are waiting for the generic until today, none of the country are requesting cabotegravir for the people. The evidence that support the cabotegravir use is based on two big studies: the randomized double-blind, double-dummy international non-inferiority, that is HPTN 083 and 84, that include MSN, transgender and cisgender women. For that reason, they demonstrate that superior efficacy the cabotegravir compared with the oral PrEP. But the problem with cabotegravir is cost, access, and we still not have a cabotegravir available for the countries. Was approved by FDA in December 2020 and incorporated for WHO in July 2022. However, the price and lack of generic limit its use and high and low and middle income country. We have the result for implementation studies in Brazil. We have a very big study in young population named PrEP 1519. Is this cabotegravir? This give them the choice for the young people to use cabotegravir or oral PrEP. In this case, 60% of the young people decide to use cabotegravir and 40% decide to use oral PrEP, and both are was a very good result of the implementation because they decide to stay in cabotegravir on oral PrEP, and the compliance was very high. The tolerance is adequate, at least less of the 2% of suspension for adverse effect, but the principal adverse effect is the pain in the site of the injection and also some inflammation. Apparently, some of the problem with resistance because the testing of HIV testing with rapid tests can be delay the reactive result. But in the last guideline for WHO, WHO recommend rapid HIV tests for testing for cabotegravir and lenacapavir because using viral load is not give us any advantage and is more expensive for the public response. In case women on oral contraceptive, PrEP can be initiated if clinical indicated. In the setting of hepatitis B status, none of the hepatitis contraindicate the use of PrEP. If the person is antigenous negative, we need to consider the vaccination and offer PrEP. And if it's positive, we need to assess for hepatitis B treatment indication. And we can initiate PrEP, but we need to refer for monitoring hepatitis B, probably be needed. And in case of transgender person and hormone therapy, is not contraindicated, but the offer needs to be daily oral PrEP for the person who are using hormone therapy. In the case of, this is the last one, is topic that I will address is the acute HIV infection. We need to roll out the sign and symptom for acute HIV infection. And we need to consider to ask to the people if have fever, fatigue, rash, myalgia, headache. And if the person has this symptom, it's important to not start PrEP and wait at least 2 or 4 weeks, preference 4 weeks. If sexual exposure in last 72 hours, do not start PrEP. We need to consider this is maybe acute HIV infections, and we need to retest. And if in the case that the person has a sexual encounter in the 72 hours, we can use PEP because this is a triplet therapy and not be involved in some blurry result, but it's recommended take the viral load for the follow-up of the person. This is a very common rash for the acute HIV infection, but if you see this rash with fever, myalgia, lethargy, and you live in the Caribbean with dengue, Zika, chikungunya, I know this is difficult for some of the countries in Latin America to get make the differential diagnosis for these people. Some cases we need to consider after the post-exposure prophylaxis to offer the pre-exposure prophylaxis. Individuals on PEP can be eligible for continuing taking PrEP if they continue at risk, and it's necessary to follow up every 3 months. It can be happen that we have an HIV reactive while on PrEP. Any reactive HIV test must trigger a formal evaluation. We need to consider the adherence practice and risk behavior and not documented. Make a individual consult and refer for HIV confirmation and eventual treatment as soon as possible. And it's important if the person seroconvert during the PrEP, we need to take the samples for make the resistance HIV test. If the country doesn't have the resources for make the HIV resistant test, we are give them opportunities to this serum can be frozen and trying to introduce on the HIV drug resistant network to make the resistant test for the follow-up. Okay, sometimes HIV test could be ambiguous and take longer to be fully reactive, but it can happen the person acquire HIV if not taken the pills like as prescribed. We need to consider the PrEP service like a platform for use for linkage to HIV treatment, for linkage to STI, hepatitis, all the different HIV prevention service like a condom, gender-based violence prevention, post-exposure prophylaxis, family planning, antenatal care, different using different system for referral, like a community mobilization or social media, etc., etc. Doctor showed this guidance is promoted the differentiated and simplified pre-exposure prophylaxis for HIV prevention. The most important thing here is we need to adapt the service to the client's needs, and we need we can offer PrEP in service, out service, community settings, mobile, with the physician, with nurses, with the community provider. We just need to be sure that the person received training to know all this testing, counseling, linkage to PrEP, substantial risk HIV acquisition package, combination HIV prevention, and it's a very good experience for community settings and differentiated and simplified service delivery to increase the number of people on PrEP. And from the beginning, we need to plan to make service most acceptable and accessible. This evidence to task sharing for increase the demand generation of PrEP and also for HIV testing, and is a sufficient evidence to recommend HIV self-testing for a start and also for continue the monitoring for PrEP in different contexts, in daily and even driven PrEP. Just in the last guidance, HIV self-testing, WHO doesn't have sufficient evidence to recommend HIV cell testing for long-acting injectable. But for oral PrEP, we can use HIV cell testing to start and to continue and restart PrEP. This is why I talking about the HIV drug resistance surveillance. The people that seroconvert during the PrEP, we need to take the samples, and we need to consider some situation for the PrEP discontinuation. This can be a personal choice. Change life situation result in lower risk of HIV acquisition. If I finish my relationship, if I decide to not have sex, well, if I don't have sex, I don't need PrEP. Some intolerable toxicities or some chronic not adherence. If the person can be adherence to the PrEP, this person can take PrEP. And the last one, and the one of the most important, is the HIV acquisition that I described. We need to linkage this person as soon as possible to the confirmation algorithm and initiate the antiretroviral treatment complete. The last one is for, remember, we need to expand the concept of a person-centered HIV prevention and care continuum. We need to put this close to the person, to the client's need, and we need to consider the HIV rapid test to the door of entrance to take all these decisions, PrEP, PEP, and also linkage with the antiretroviral treatment in the case of the HIV rapid test can be positive. Remember, no single prevention intervention can reduce the new HIV infection. The community involvement is important for the provision and distribution of HIV testing and PrEP, and also can improve the acceptability between the communities. And we need to simplify the country in delivery for PrEP because this can benefit for the adherence to compliance for the people to taking PrEP, and finally impact the HIV incidence of reduction. Thank you. Thank you very much. I know this is very long PowerPoint presentation, but normally we make this long time, more time, and suppose in this moment we need to have the clinical discussion, but I know you are tired. It's up to you if we can continue tomorrow with the clinical discussion because we have time tomorrow. And if you have, I will see the chat. How do you know that someone that has never used PrEP has a contraindication to PrEP? Yeah, you need to talk with the client because, for example, if this person is more than 30 years and diabetic or has hypertension, maybe you need to make a creatinine test before they start the pre-exposure prophylaxis. But the reality is that most of the people who are acquiring HIV is very young and normally doesn't have any other conditions that together with the risk practice. Probably you can know before if this person doesn't have the kidney impairment. But the good news is if you start PrEP and have the kidney damage, this damage is totally reversible when you stop PrEP with tenofovir disoproxil. You stop PrEP and make another test, and this impairment will be totally reversible. before the physicians and the countries has a lot of fear to start PrEP because this kidney impairment. But the experience from the implementation study said it's better that you start PrEP, and if you have the kidney impairment, you stop PrEP, and all the damage will be reversible. In case of
Yeah, I was referring to the allergy or
yeah,
hypersensitivity.
I'm trying to I'm trying to
Sorry for that.
So in case of allergy or hypersensitive, probably you will not. At, just in case that the person who received previous, for example, post-exposure prophylaxis and receive tenofovir or emtricitabine before for PEP, and some people can set the blue pill or some HIV pills give me allergy. It's better to offer another different option. But in our settings, in our context, it's extremely rare. Uh, we support different countries for implementation, and I don't want to see very I don't know what I because I don't have all the information. I don't want to say, but I don't see any of this hypersensitive. I try to remember probably one case in one country in South America. But the best thing that I can recommend is monitoring, register, systematize, and prepare all the field for the report all the adverse effects and monitoring. Dice, when using PrEP, we test client who was exposed, then treat if negative. When using PrEP, we test client who was exposed, then treat if negative. Do we still consider testing following the window period for HIV testing? Okay, I try to understand. The HIV rapid test has a very high specificity. You know, if the HIV test is negative, the 99% of the cases will be negative. If this person has a sexual intercourse very close to the HIV test and you have doubt, if between the window of 72 hours, offer PEP because post-exposure prophylaxis is 99% effective for HIV prevention. If the person window is more than 72 hours, you can offer PEP and you only need to wait 4 weeks for retest if you have any doubt. But the majority of the person can come to our site and make the consult. If the HIV test is negative, you can start PrEP without problem. If the person said, I have sex yesterday without condom with more than one or just one, you can offer PEP. For that reason, we are talking about PrEP / PEP because all the PrEP programs need to offer post-exposure prophylaxis to give them choices to the people in the different settings in order to prevent HIV. Is the last contraindication relevant if one can use TAF? Like the point is that WHO doesn't recommend TAF between the WHO guidelines. But if you have available TAF, you need to know this not generic supplies for TAF and tricitabine combined that I mentioned before, but you can give the people separate if if they have a kidney impairment. Yes, you can have this video in the PowerPoint presentation that I shared with Shanti is the link. I think Caribbean also have another tools for the patients. Will event-driven PrEP not lead to resistance in case of an active hepatitis B virus infection? Resistant in what case? For HIV or for hepatitis? Because hepatitis is a hepatitis virus is very latent infections. The reality is need to consider the assessment for hepatitis, but in HIV, no. It's not considered the HIV resistant. What tube to use for resistant testing? Oh, that's one. I don't know. But for tomorrow, I will know because I think, but I am not sure. And tomorrow I will set what tube you need to use. I assume that is a chemical, the red one, because you need to separate
It's
serum.
the lavender colored one.
Lavender in Latin
Yeah.
America, red, sorry. Yeah, for that reason I said tomorrow, but if you know, thank you. But you need to separate the serum and frozen the serum, yeah, accordingly to laboratory guidelines. How frequently do you monitor patients who refuse PrEP? Okay. Listen, how frequently do you monitor patients who refuse PrEP but is in a serodiscordant relationship and claim condom use? Okay. This is a complex question, but a good question. First, because be in a serodiscordant relationship is not an absolute indication for PrEP. Because if the HIV person is receiving treatment, is undetectable, is untransmissible. You know, undetectable is equal to untransmissible. And if this person, if this client is only has sex with this HIV person, testing is every 3 months. But we don't have any strong recommendation for testing, for example, more frequently. But I will say if they are using condom, are undetectable, are untransmissible, and no more high risk to other person. I don't know if it's clear the answer, or if this has some case specifically. It's better to analyze the case complete, you know. But testing is not more frequently if the person is undetectable and use condom. But if so, if only have sex with this person, no more risk. But if have sex with another person, okay. I suggest to continue tomorrow. I suggest the same because probably you are tired. I'm not tired, but probably you are tired. I have the tendency to talk a lot because this I passionate for this subject. But I said very, 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 very thanks a lot. Tomorrow we have the clinical discussion, and we can trying to be more interactive in the discussion part. Okay, thank you very much, Dr. Kisha. You can close the today workshop. Thank you. If you have any question, please don't hesitate to send to to the coordinators and they give us the question and we'll try to make the best answer for you.
Thank you very much, Dr. Hortensia, for your presentation. And definitely you can see from the questions that have been posted in the chat, it's definitely answering to the objectives and to the interests of the participants that we have here this afternoon. I know I'm slated to do closing remarks, but I think a lot of us are eager to get off of the call, so I'll keep it very short. Today's session was definitely a very interactive one, as you can see from the participants, their feedback, the comments that they have made. We know yourself and the other presenters today, you all come with a wealth of knowledge and experience. So once again, thank you for sharing your presentations with us, allowing us to ask questions and responding to those questions from the participants. I'm hoping that today's session was very fruitful for the participants. We would have been able to answer, as I said, the objectives and the interests that they would have shared. As you guided us earlier through the Mentimeter, I know we looked at the facilitators and challenges for PrEP, looked at how PrEP being, or oral PrEP rather, being one of the most powerful tools against HIV prevention, how the importance of evidence-based has really shaped those guidelines and allows us to have effective practice. And then with your presentation there, understanding the various PrEP modalities, how they should be administered, to which specific groups or clients we should apply those different modalities to. So today's session was really great. I know in the interest of time, we've all agreed that we will not be doing the case discussion. So please come tomorrow refreshed and prepared for the case discussion first thing tomorrow. And also to allow our presenters again, myself included, to walk us through tomorrow's presentation. So thank you to everyone that's on the call still, and enjoy the rest of your evening.